Thank you very much for the kind introduction, Alex, and thank you, Vivian. It's my pleasure to be here joining you in this wonderful conference. When I left Seattle yesterday morning, it was 48 degrees. When I landed here yesterday evening, it was 98 degrees. So thank you for the warm welcome. I have nothing to disclose. I have a long title. I try to focus on 4 areas. We want to start with a time travel. I've been presenting this topic for the last 30, 35 years, and we have seen a pattern of things that is going on after 5, 7 years. And part of it is we have not had any major breakthrough in this research area. So what I would like is to go through a little bit of time traveling. First, start with the okay. First, start with the scientific merit of looking at micronutrient supplements in this area. Then we move on to some of the clinical trials. We will just highlight some of the clinical trials. And then we'll look at what we have learned in these clinical trials, focusing on different micronutrients. And then most of all, we'll conclude with what our future directions should be, in my humble opinion. My goal is to challenge the status quo, stimulate some discussion, and invite collaboration. So let's start with the science. Let's talk about the scientific basis of using micronutrients during critical illness. Here is a really, really simplified illustration of what's happening during acute illnesses. We use infection as the cause. It triggers sepsis, which leads to apoptosis. And then the downstream effect is there are multi-system responses, ranging from the immune system, the epithelial system, and the endothelial system. All together, they triggers a massive inflammatory response. And then as a result, it imbalances our immune response and antioxidant systems. Now, the change in barrier function will also lead to bacterial translocation that affects our intestinal microbiome. And I'm looking forward to Gail's presentation to discuss that further. And just to sum up, right, systemic inflammatory response is the most common response associated with critical illnesses. The inflammatory response is triggered by both the invaders as well as the host. So it is massive and it is difficult to control. This inflammatory response results in a dysregulated immune function. And if not controlled, it can lead to multiple organ system failure and death. Interestingly, micronutrients are involved in the regulation of the inflammatory anti-inflammatory cascade, which help us transition to this slides. Now, it looks really complicated and is put it on purpose because the regulatory process of our immune response and inflammatory system is in fact a very complex process. Just to highlight a few things, right? With sepsis, it triggers the white blood cells to release hydrogen peroxide and superoxide molecules. They're neutralized by an enzyme called superoxide dismutase. Now, superoxide dismutase is a zinc-containing, copper-containing, and selenium-containing enzyme. So now you can see the importance of having certain micronutrients. Downstream here, you see N-acetylcysteine, as well as glutathione. These are selenium-dependent enzymes to down-regulate inflammation. Further down the road, as we produce nitric oxide and other pro-inflammatory mediators, vitamin E and vitamin C collectively serve as antioxidants to stop this inflammatory process. Importantly, vitamin C and vitamin E will be used up as antioxidants. Now they have to be recycled, otherwise they themselves become pro-oxidants. The recycle process involves iron, copper, and other micronutrients. So to sum up, you can see that multiple micronutrients are involved in regulating the immune response. And in order to stop or decrease inflammation, it's difficult to pick just one micronutrient and hope for the best. In addition to anti-inflammatory effects, there are some evidence that, for example, vitamin C has pleiotropic effects. It is a cofactor for dopamine beta hydroxylase and tyrosine hydroxylase. So theoretically, by infusing or replacing vitamin C in patients who are hypotensive, it can enhance the production of catecholamines and may help sustain blood pressures in patients who are in shock. Now, that's proven in very, very small clinical trials. There are also in vitro data and animal data suggesting that vitamin C regulates endovascular permeability. They have not been proven in clinical trials at this point. And to be complete, I want to point out vitamin D as well, because that's another compound of interest in the last 5-10 years. Vitamin D is a gene regulator, is a hormone. One of the most interesting effects of vitamin D is it regulates genes such as beta defensin and calythicidin. These are enzymes that help cleave the membrane of viruses, which makes it an interesting target to look at COVID and other viral infections. So putting this kit together, at this point, I think from the scientific basis, we have enough reason to believe that micronutrients should play a role in regulating inflammatory response. And we can move this into clinical trials. And that's exactly what happened. And let's look at our second objective. What have we observed in clinical trials? Now, here is a timeline of clinical trials. We can break it down into several timelines. In the 80s, the studies focused mostly on total antioxidant capacity, which is basically a quantitative measurement of how much antioxidant is being depleted and being replaced in patients who are critically ill. Then the trials moved on to look at specific micronutrients, with most focus on antioxidants. Later on, in the 90s, the studies started expanding to selenium. And then a combination of antioxidant vitamins, seleniums, have been used thereafter. And then, of course, in the last 8 to 9 years, the primary interest was in vitamin C. And I'll highlight each of them briefly. So to start with, here is the original data looking at antioxidant status. On your left, the measurement is lipid peroxide, which is a cellular breakdown product of oxidative stress. You can see that looking at the concentration, right? Patients who are in shock, septic shock, have significantly higher plasma concentration of lipid peroxides, suggesting that shock, critical illness, does seem to increase oxidative stress. And you can also confirm that by measuring total antioxidant capacity. So if the total antioxidant capacity or TAC is low, it suggests that the body antioxidant system and some micronutrients have been depleted. And you can see that critically ill patients have statistically lower total antioxidant capacity. If we start focusing on specific micronutrients, as early as in the 1990s, we have seen that ICU patients have substantially lower vitamin C concentrations in the plasma compared with healthy individuals or those with other comorbidities. And that's also true when you expand our profile. Vitamin E concentration in patients with multiple system organ failure is about half of those in healthy volunteers. Vitamin C, again, substantially depleted. Now we start to see selenium being depleted. Now, what's interesting is the functional measurement is not changed. Glutathione concentration does not seem to change significantly. So it does raise the question of what is the valid measurement, and we'll keep that in mind. Another breakthrough is to look at the change in antioxidant status. Felicity Harker published this important study showing that the longer you stay in the ICU, the lower the plasma selenium concentration you have. Now, it may be that because you don't get enough feeding, so as a result, you depleted all the selenium. So that does raise the concern that nutrition support is perhaps important. But her data was complemented by Alonso de Vega's study, showing that when you look at Apache 3 score, the sicker you are based on increasing Apache 2 score, the higher the plasma myeloperoxidase concentration is. Now, this is an enzyme released by white cells that lead to oxidative stress. And the increase in oxidative stress with increased critical illness correlate with a much more substantial depletion on antioxidants. So collectively, we start to put together a picture where, number one, ICU patients will have depleted antioxidants. And the sicker you are, the more likely you have depleted micronutrient and antioxidants. So perhaps we can try to replace them. This study was from our center, University of Washington, back in the early 2000s. This is in a trauma unit. The goal is to give our patients in trauma unit a cocktail, vitamin E and vitamin C. You can see the dose are substantial. Now, these doses are somewhat arbitrary based on the safety limit. And that's one thing we have to readdress later in dose-response relationship. Trauma patients receive vitamin C 1 gram IV every 8 hours and vitamin E 1,000 units 3 times a day for up to 28 days. The primary endpoint is survival and end-organ failure. Unfortunately, as you can see here, when you look at clinical outcomes, there is no difference in spite of giving such high-dose combination and vitamin C and vitamin E. A few notable things. These are young patients, 39 years old on average, because these are trauma patients. These are not typical medical ICU geriatric patients. Number two, important to point out that if your baseline mortality rate is 2%, it is difficult to prove survival benefit. So there are major intrinsic limitations this trial. This is just one of the many studies leading to an array of combination trials. The next break comes from this study published from our friend Darren Halen in 2005. And you can see that our own study was included here. And their group reviewed all the antioxidant micronutrient trials in critical ill patients at that time and tried to see whether there are benefits. Well, there are two things I want to point out. Number one, if you look at the overall effect, it does suggest that micronutrient supplementation may offer some benefits with the 95% confidence interval at 0.97. However, if you look closer, the only study that shows benefit is this Kokinski study. Every other study failed to demonstrate any benefits except the Kokinski study. Now, this is an interesting study because this study is an acute pancreatitis study. And if you look at the study, everybody in the placebo arm died. Everybody in the treatment arm lived. So this is really an outlier. However, this does lead to the next 15 years of the focused research in selenium. Now, Darren looked at selenium data one more time, and they start looking at pattern. Unfortunately, whether you look at overall benefits or a dose cutoff at 500 micrograms per day, there seems to be no significant survival benefit. As I mentioned, it did stimulate a lot of interest to look into this area. So here we are. We continue to have this area of research. I want to show this study from Armstrong in 2007. That was the first substantial study suggesting that there may be some benefit of selenium, called SIC trial. A couple of things to highlight. The dose of selenium is huge. 1,000 micrograms of sodium selenide as a bolus, followed by 1,000 microgram continuous infusion daily for 14 days. Who are these patients? We have shifted from our UW study looking at trauma patients to older adults, medical ICU patients, age in the 60s. Now, the bottom line is there was no survival benefit. When you look at the survival time, it's 20 days versus 17 days. However, if you start digging into subgroup analysis, in the subgroup patients with septic shock, there seems to be a little bit of survival benefit. So it sheds a little bit of light to continue the field of research. Now remember, that was 2007. Here is one of the studies published more recently in 2016. So it's still going on. Again, look at the dose, big dose. This time, no survival benefits. Again, we are looking at the same population, age in the 60s, Apache 2 score in the 20s. Infusion time, about 16 hours. 28-day mortality is 28% versus 25%. So if we were to summarize what happened in the selenium-focused research in the last 15 years or so, we have about 23 RCTs. That's a very, very large number. None of them show overwhelming promises. There are intrinsic limitations. Number one, if you look at the dose, if we believe in dose-response relationship, right, we think of it as a drug, as a treatment. The dose of selenium in these 23 trials range from 500 micrograms per day to 4,000 micrograms per day. Okay, so there's a huge variability. The other thing that was not well controlled is the control arm. There is no well controlled on the amount of selenium received in the control arm, ranging from nothing to 70 micrograms plus, and then on top of it from their feeding regimen. The primary outcome of interest has been survival, overall survival, as well as 28-day survival. So it's important to think about the fact that whatever negative finding we observed is mostly with survival. We don't really have enough data to look at other secondary outcomes or other potential benefits. With the interest of selenium continues but not making breakthrough, one of the new kids in the block is vitamin C. Many of you are probably familiar with this study published by Paul Merrick back in 2017 in Chest. It is a retrospective trial comparing the effect of hydrocortisone, vitamin C, thiamine combination in patients with septic shock. You can see that a dose of vitamin C is 1.5 grams every 6 hours until ICU discharge. And this study was very interesting and arouses a lot of interest because, as you can see, if you look at mortality, those who receive hydrocortisone, ascorbic acid, and thiamine had a 30% net reduction in mortality. The placebo arm had 40% mortality rate. The treatment arm had 10% mortality rate. Now, if this is real, this is humongous. When you look at other secondary outcomes, the duration of pressor, the duration of mechanical ventilation, they all favor this combination. The challenge is, amongst every single randomized controlled trial published thereafter, nobody can replicate the results. And here is a summary of all the major RCTs published since our study. And you can see that the only study showing a potential positive survival benefit is the Citrus ALI study. Now, this study focused not only on sepsis, but also acute lung injury. So we have a slightly different patient population. Now that's concerning, right? When you have a retrospective study showing such benefit, but none of the RCT shows anything close to it. The other thing I want to point out is if you look at all these RCTs from the last 5 years, again, the mortality rate of the control arm varies dramatically. It is more likely to demonstrate some benefit when your baseline mortality rate is 46%. It is much more difficult to demonstrate benefit when your baseline mortality rate is only 15%. Now, why do we have such wide baseline mortality rate across the group? Well, patient populations are different. And in fact, I can argue that the ICU patients here in Emory probably may not be compatible with some of our medical ICU patients at the University of Washington. Comorbidities, treatment, other variables. The other thing to keep in mind is there are other areas in critical care that has been evolving, which may contribute to some of the changes in survival. Well, following the approach with selenium, when we are not able to find trends, we go to meta-analysis, and there have been a lot of meta-analysis on ascorbic acid published in the last 3 years. One of a better written study is from our colleagues here in Aspen, Jay Patel. This paper was published in 2002 in Critical Care Medicine. Again, if you look at every single study published involving vitamin C, it doesn't show any statistically significant survival benefit. You can see that the 95% confidence interval just hit 1.0. Well, following Darren's footstep, why don't we start teetering and looking into subgroup? So when Jay looked into different studies, he found a small trend. IV monotherapy of vitamin C is probably more likely to lead to survival benefits. Number two, higher doses of vitamin C may make a big difference. So to sum up, vitamin C by itself probably is more effective than combination. Number two, you need to use a higher dose of vitamin C. Well, with that, do we have RCTs to prove it? Well, timeliness is everything. So his new hypothesis can be reviewed by 2 clinical trials he's published in the last 2 years. First one, looking at septic shock. This involved 5 sites in Minnesota. All right, vitamin C alone, look at the dose. 1 gram bolus followed by 250 milligrams per hour. Duration of infusion is 96 hours. So these patients received up to 25 grams of vitamin C. What did they show? If you look at the 28-day mortality, it looks like there is a 14% net reduction. That sounds good. Unfortunately, it did not reach statistical significance. So again, we may see a trend of some benefit, but it did not translate to clinical significance and statistical significance. And if you look at other parameters, the change in SOFA score, ICU length of stay, the duration of vasopressors, again, no difference. It is important to, again, go visit who these patients are. They're in the 60s. So we have been focusing mostly on older adult in the 60s, Apache 2 scores in the 20s. Well, I mentioned the other alternative hypothesis from Jay's meta-analysis is really, really high dose vitamin C. You go, the Lovett trial. This is a multi-nation study, including sites in Canada, France, and New Zealand, with 35 medical surgical ICUs. It was randomized 1-to-1 between vitamin C and placebo. Now, the vitamin C regimens involve a total of 96 hours infusion, up to 16 doses at 800 milligrams per kilo. Again, we are talking whopping doses of vitamin C for these patients. If we were to translate to the amount of oranges, right? One orange gives us roughly 80 milligrams of vitamin C. So we are talking about eating 100 oranges, but you give it injection. What did the data show? If you look at the Kaplan-Meier curve, it looks like the two lines once again overlap. But in fact, if you look at all-cause mortality and any organ dysfunction, there is actually an increased risk of dying and or organ dysfunction with vitamin C treatment. So that's sort of a shocker to most of us. If you focus on 28-day mortality, once again, the difference is extremely small and it is statistically insignificant. Once again, these are folks in the 60s with a PATH-2 score in the 20s. The study did look at other secondary outcomes. Organ dysfunction, no difference. Death by 6 months, no difference. And they look at other functional changes. And I'll highlight in our later discussion. So what is our road ahead? To summarize where we are, right? We started out with a scientific hypothesis that antioxidant micronutrients is depleted in critically ill patients because of inflammation. We have early data to show that it is true. Plasma concentrations of these micronutrients are changed. That leads us to start exploring micronutrients one by one in clinical trials. The combination of ascorbic acid, vitamin E, selenium show no difference. The selenium alone interventions show no difference on survival. The vitamin C trials, most of the RCT show no difference. So are we stuck? So let's explore what we have learned from these last 30 years. 3 points I want to raise. The biological samples, what are we measuring? Do we understand the dose-response relationship? One of the points I brought to you earlier is that the doses were everywhere. Now, are we just guessing? Or do we really have a basis to use those regimens? And lastly, are we looking at the right outcomes? Now, this graph very, very nicely summarized the confusion we are having at this point. We are focusing on just copper, zinc, and selenium. There are different studies measuring different biological samples. Some studies focus on serum, some studies focus on plasma, some studies focus on red blood cell selenium. Now, this doesn't include studies looking at total and whole blood. And if you put on the hat of drug therapy, right? What biological samples we are looking at in measuring drug level matters. When we have different samples, different biological samples, it may interfere of how we interpret the clinical data. Number two, there has not been established studies or ethics in quantifying these micronutrients across the board. So there could be study and assays variance from study to study, from hospital to hospitals. Dose-response relationship. These are plasma concentration of vitamin C and vitamin E from our University of Washington study. Now remember, the vitamin C dose is 1 gram every 8 hours in the treatment arm. In the control arm was basically whatever they received from feeding. So the average intake is about 60 to 100 milligrams per day. So what we are talking about is in the treatment arm, they receive somewhere between 20 to 25 times higher of vitamin C dosage. Well, if we do believe in dose-response relationship, their plasma vitamin C concentration should be 20 to 25 times higher. It's not. It's only 1.5 times higher. What happened to the vitamin C you infused? Same thing is true for vitamin E. the daily vitamin E intake in the control arm is about 40 units. The treatment arm received 3,000 units. So we are talking about 100-fold increase. But the vitamin E concentration in the plasma is only about 5 times higher. And this is actually confirmed by some of the kinetic studies looking at vitamin C infusion. So what you're seeing here is in healthy volunteers, they receive different doses of vitamin C, 1 gram, 5 grams, 10 grams, 25 grams, up to 100 grams. What you do see is the maximal plasma concentration increase proportionally. If you increase the dose by 10 times, the maximal plasma concentration is increased by 10-fold. But the overall exposure area under the curve did not increase by 10-fold. It's only increased by 5-fold. So the question remains, when we give so much antioxidant micronutrients to our patient, where did it go? Or are we measuring the valid marker? This is also confirmed by some of the newer PK studies, and we look at vitamin C concentration between 2 grams and 10 grams bolus. We see the same pattern, right? By giving 10 grams, the peak concentration is indeed 5 times higher than what you see in 2 grams. But the trough concentration does not increase by 5 times. So clearly, vitamin C is redistributed after infusion. The other thing to point out is by giving in a different method, bolus versus continuous infusion. Now you can see that by giving 10 grams continuous infusion, the change in plasma concentration is actually smaller than 2 grams. So again, the kinetics of these micronutrients require further exploration. Last but not least, I want to highlight safety and efficacy. When you give large doses of vitamin C, especially intravenously, there are a couple of concerns, right? Number one, oxalate formation. Now, panels A and B measure urine oxalate concentration between 10 grams, the red line, and 2 grams, the blue line. The good news is, yes, there is a dose-dependent formation of oxalate, but it is not that difference between 2 and 10 grams. What's interesting is when you look at acid-base changes, panel C measure base excess change. And you can see that by giving 10 grams of vitamin C bolus, there is a substantial change in base excess. So it looks like when you give 10 grams bolus of ascorbic acid, it shifts acid-base balance significantly. Would this shift in acid-base balance somehow offset other clinical benefits, which in turn results in lack of survival benefit? I think these are a lot of questions we can now start to explore. And I want to kind of sum up what we have learned from the last 30 years clinical trials with this graph. On the y-axis here is the combination, and 0.0, no difference. 0.3 favors the use of antioxidant vitamins. -3, not favoring. You can see that essentially there's no effects. Give this time to process. We spent 30-some years, and it doesn't look like we're moving our meters. So where should we go? And I think that's my focus in the next few minutes. One of the first questions I want to put out is survival the best clinical outcomes? I think it is the goal we all want to see, right? We like to see the interventions results in improved survival, especially in critical care trials. That's our gold standard. In the last 30 years, with different micronutrient research, we failed to reach that goal. Now, does it mean that this is not a viable research? I don't think so. the question I think we want to step back and think is, are we looking at the right clinical outcomes? Should we focus only on survival? Now, just to open the discussion a little bit further, right? The majority of the clinical trials focus on 28-day survival. We understand that our critical ill patients have very different clinical presentations depending on the causes, right? We have not looked at survival in the first 48 hours. We have not looked at survival in the first 7 days, especially amongst patients who are in septic shock, hypotensive, requiring renal replacement therapy. So is it possible that some patients are better responders to these regimens, but when you spread it out to 28 days for everybody, you just don't see the difference? We talked about measurement. It's true that we have non-standard measurement, we have different blood samples. The other thing to think about is knowing ascorbic acid and vitamin E as two examples I showed you earlier, they don't show dose-response relationship in the plasma concentration. Should we look at other surrogate marker to better reflect the clinical response? For example, when you look at these antioxidant micronutrients, most of them function intracellularly. So perhaps measuring what's in the plasma may not be the best representation of what's going on inside the cell where they focus on the mechanism of action. Did we give too much? Some of the vitamin C doses are humongous. Keep in mind that in both in vitro data and animal data, there is such a thing called pro-oxidant effects for antioxidant micronutrients. Meaning, if you give too large a dose of antioxidant micronutrients, in the absence of a lot of free radicals, these antioxidant vitamins become a pro-oxidant and they start attacking cells. So now when you go back to the regimen where we give these high doses for 96 hours or selenium for up to 15 days, are we over-treating our patients? And that leads to some of the dose optimization, right? Again, if we put on the hat of pharmacotherapy, we try to personalize, individualize the dose. And we can see that in our clinical trials, we didn't do that. I mean, it is a huge step in more recent trials where vitamin C was weight-based as opposed to the early 2000 trials you saw and show you that everybody give the same standard dose. So there are a lot of work that can be done in optimizing and personalizing these regimens. And I'm glad to see that we are seeing that in newer trials, but we certainly have a long way to go. To wrap up the clinical outcomes, right? Again, I want to go back to whether survival is the best clinical outcomes. I go back to the same analogy. Are we trying to look at this really complex inflammatory, anti-inflammatory system, and we just pick one micronutrient? Very much like, well, let's eat 100 oranges, and then it will improve survival. Perhaps the benefit may involve longer term. Now, what we have been focusing on in most of the critical care trials is 28-day survival. There has not been enough research focusing on long-term impacts. This is one of the few studies looking at 6-month psychological and functional outcomes in ICU patients after receiving vitamin C, thiamine, and hydrocortisone. Now, when you look at the findings on the surface, it is a little bit disappointing because, again, nothing jumped out that seems to be statistical significant. But I think this is a start. If we do believe nutrition support, promote healing, and it involves long-term benefits, I think we need to start focusing on long-term outcomes of our patients rather than focusing on 28-day survival alone. In the LOVET trial, they also start addressing quality of life. You can see that they look at a European tool to look at health quality of life that measures mobility, self-care, usual activities, pain, discomfort, anxiety, and depression. Again, on the surface, there doesn't seem to be major benefit in this particular trial. But again, because it's a secondary analysis. So moving forward, what we can expect is to start planning and thinking about clinical trials that look at outcomes way beyond 28-day survival alone. Now, I'm going to close out with 2 additional slides here. In the last 15 years, one of the push that myself and a lot of other colleagues has been to understand the dose-response relationship. Now, we start to see the data. So there are really high quality research start being published. And here is one example that look at vitamin C kinetics in ICU patients, not just healthy volunteers. You can see that by repeating the doses, the plasma concentration of vitamin C start to rise. So this is the 3rd dose, the green line is the 4th dose, the blue line is the 5th dose. And then by the 7th dose, the plasma concentration is dramatically elevated. It opens up opportunity that maybe the duration of treatment can be scaled back, or maybe by day 7, the dose can be scaled back to prevent the risk of pro-oxidant effects. We also have kinetic parameters to look at the disposition of vitamin C. And the clearance, we know the plasma half-life, which is actually longer than healthy volunteers. Healthy volunteers has a plasma half-life of about 2 hours. In critically ill patients, vitamin C has about twice the plasma half-life. So it's cleared much more slowly. Last but not least, I want to kind of put this graph to kind of put us back into perspective. The cooperative nature of micronutrients in the inflammatory cascade. We start with a stress, we start with inflammation, we start with triggers. It generates free radicals. The free radicals start attacking the cells. Well, we have antioxidant micronutrients to stop that process. But you can see that every antioxidant micronutrients kind of collaborate with another one. And it depends on another antioxidant compounds to continue to function. So it may be a challenging task to focus on just one compound when the entire cascade is linked. So to sum up, right, not only are we trying to dose optimize individual micronutrients, we also have to start finding the best combination in different circumstances, in different patient population to really make a breakthrough in this area. And then last, I want to leave you with this. When you look at the number of meta-analysis published, systematic review, look at the change. We have way more systematic review meta-analysis published than RCT or even retrospective trials. And while we recognize the string of systematic review increase the N, give us stronger confidence on whether we're heading to the right direction. Systematic review also inherits every single limitation from the clinical trials. So are we kind of chasing our own tail because each of the clinical trials have limitation and we keep publishing a systematic review and we are just enhancing the weaknesses that have been inherited from the trials? I think there are values moving forward to continue to focus on RCTs. If you talk to Todd Rice, we have debates on whether or not we should look at pragmatic trials. And I think, in fact, observational trials have their roles, and we have to have a more complete profile to move forward, because for 30 years, we are really going in the same loop. And I would hate to say in the next 15 years, we just pick another micronutrients and reach the same dead end. So to summarize, micronutrient supplementation in ICU patients has been investigated for over 3 decades. There is clear scientific basis for the approach, but when you look at the clinical results, they have been mostly disappointing. The basic science is solid, but when you look at the compounds of choice, we have been focusing on selenium, vitamin C, and then a few antioxidant cocktails, especially vitamin E and vitamin C. When you look at the demographic, right, the patient populations being investigated in the last 15, 20 years are mostly 60-year or older, mixed ICUs. We really don't have data on younger adults. We don't have data on even older adults. So again, we may not be able to generalize this particular age group into all other patient populations. So moving forward, we talked about clinical outcomes quite a bit. So I think it's time for us to start thinking through what are the clinical outcomes we should explore. And in my opinion, including long-term clinical outcomes rather than just 28-day survival. We talked about dose optimization and the differences in route administration, as well as how it is administered, continuous infusion versus boluses. And that is going to be continued focus. And I also urge that if you are publishing any data, provide clear instructions of how you administer the micronutrient, because that matters. Finding a defined patient population, one regimen works for this population, may not work in another population. So not overgeneralizing to all critically ill patients. And then while we continue to use meta-analysis, let's make sure we're not using that as the only drive for our research in this field. With that, I think I'm going to pause here. There are 3 assessment questions. Okay, so which of the following is a theoretical benefit for vitamin C in patients with septic shock? Feel free to yell out. Right here, C. The correct answer is B. Remember, it is part of the cofactor for dopamine B hydroxylates. So there are some preliminary clinical trials suggesting that adequate vitamin C concentration may enhance production of catecholamines. It does not suppress neutrophil chemotaxis. It seems to suppress the release of antioxidants. If you look at the Lovett trial, which of the following is the primary outcome finding? Close. Yep, you were spot on. It does show increased death or persistent organ damage at 28 days. Compared to healthy volunteers, the plasma half-life of vitamin C appears to be increased from 1.5 hours to about 5 hours. And then lastly, which of the following outcomes regarding micronutrient therapy in ICU has not been adequately evaluated? Functional status. So again, I thank you for your attention and the opportunity to share some of my thoughts in this area. It continues to evolve, and I think we have a lot of work to do, and hopefully we'll continue to make some breakthrough in this area. Thank you for your attention. So the question is, has anybody looked at other compounds that can alter transcriptional factors for inflammation? Some of the compounds being looked at include corticosteroid, hydrocortisone as part of the regimen. Thiamine has some transcriptional effects. One thing I leave out in this particular presentation is vitamin D. As I've mentioned, vitamin D is a gene regulator. So there are clearly some preliminary studies moving forward, and we'll keep an eye on it. A brief comment on vitamin D. I think vitamin D is a very different compound in so many ways because it regulates over 3,000 genes. Vitamin D is also an acute phase reactant. So it comes down to, once again, what are we measuring? Is it like albumin? It drops because in response to inflammation, vitamin level drops. Or does it really mean something by replacing the deficit? Yeah. Yeah, interesting comment you have for resveratrol and other compounds, right? You bring up an important regulatory question. And one of the major challenges of using these compounds is regulatory. I mean, think about it, resveratrol is not an FDA-approved drug. So you have to make sure that whatever clinical trials that we are studying has a compound that is clean and purified. And in fact, that's one of the intrinsic limitations of a lot of the micronutrient trials using non-intravenous products, because they would be using dietary supplements. So now the quality may be in doubt. And the IV vitamin C studies, the IV selenium studies translate to better quality control. The question is adding ascorbic acid directly into parental nutrition in critically ill patients. The biggest challenge is stability. That greatly limits how much ascorbic acid should be added, both from the safety standpoint as well as compatibility standpoint. I see Gordon back there, and they probably have much better data from Francina to share. But this is at least one of the concerns, especially when you're talking about 80 milligrams per kilo. That is a huge dose to add to any standard PN in terms of causing precipitation, deactivation of other micronutrients. Thanks, Gordon. So the question is, in some of the studies I shared with you demonstrating the pharmacokinetics of micronutrients, what technique do they use? Do they use reliable techniques such as tracer? The studies I share with you did not use tracer. And I agree with you, ideally, we need to use tracer because by using tracer, which is a nucleotide or isotope, we can actually follow exactly where the compound go. Number one, it provides more accuracy. Number two, it gives us a better idea of the disposition of the compound. And number three, I think what you were alluding to is we receive compounds such as ascorbic acid from enteral feeding from other sources. So how do you know this is not your body's own compound or through feeding? So none of those studies use tracer. I agree that would be the ideal technique. In those studies, however, one of the claims is that when you give 5 grams or 10 grams, the change in plasma concentration is substantial enough that you can measure a meaningful trend. And I think that's consistent with how we look at some of the electrolyte studies, right? Whether it is magnesium administration or phosphorus administration, this bolus doses give us a significant change enough in plasma concentration that at least give us a little bit of a sense of the trend. I'm sorry, can you repeat it? Thank you. So the question is, when would be the optimal time to check certain micronutrient concentrations in critical ill patients? I wish we have the playbook to really explain it. I think you stated it very, very well, that some of the compounds are negative acute phase reactant. So they are supposed to be low. And my example for that is zinc. Every ICU patient should be zinc depleted. So there is really no point to check zinc. Checking zinc is very much like checking serum albumin. It is supposed to be low. If it is not low, well, it will be low. But it doesn't mean we don't act. We do know that, for example, ostomy output diarrhea will increase zinc loss. So then empirical supplementation would be helpful. With regard to other compounds, such as ascorbic acid, some of the preliminary data in the 90s and 2000 show that, yes, they are low. So if you check them, they should be low. I think the biggest question is, if we check it, what is the implication? And I think that's where we don't really know. So to put that into an action plan, right? My suggestion is, at this point, empirical measurement of micronutrients may not be of value for every patient. Now, it doesn't mean that they should not be administered or replaced in a patient who is at risk for micronutrient deficiency. Some of the wonderful work published here at Emory, including loss of micronutrients in CVVH, right? And so those patients should receive supplementation on top of daily intake. And then in addition to that, if you have any reason to believe this patient is at higher risk for micronutrient deficiency in spite of supplementation, I think that makes sense to proceed and to perform routine monitoring, just to give yourself a trend. Yeah, I share your approach is that one of the, from console is, all right, let's check this. And then we have the level, and you get a level back and you look at it, so like, now what are we going to do?